Zach.
Muzak. It was kind of Muzak. Okay. Hi, everybody. We have 0 people watching yet, but somebody will log in soon. This is Dr. Hooper. Hello. Still a 0. Someone will replay it and be like, how long did they just chit chat? Who knows? So we'll just hang out here for a minute, and I'm going to send the office a message that says, "Hey, everybody, log in." Seriously, I am.
Nice. Like, no, for real. Log
For
in.
real. Lifetime. Okay. um, so Atlanta is good, right?
It is,
Yeah,
actually.
good,
It is. This is
good.
home, though, so
Oh, that's right.
it's nice to come
Yeah,
back.
yeah, for sure. So can you see the little comments on the side of this?
Yeah, I see.
Okay.
Wait, I'm in private chat right now, but yes,
Okay. Yeah.
I have
So
that.
it should show us some comments when when somebody leaves us some of those. So that's good.
Okay.
Okay, we got one. We're pretty popular. We're gonna make this thing grow.
Wait, we do the one. You mean the one from StreamYard?
Well, no, there's a little eyeball with a one now. Somebody from our Facebook page is watching.
Oh,
Hi,
yeah. I don't.
person.
Hello, person. Welcome.
Welcome.
I don't.
So I'll keep you posted. Oh, we got two. We're
We're
exponential growth.
cooking with hot grease now. This is great.
Get ready, get ready. So, for those of you who are kind enough to log in, I'm Dr. Hooper, and I am joined today by Dr. Ryland Gore. And Dr. Gore and I have known each other getting to be quite a few years now, but it's been a while since we've seen each other. We'll blame it on geography and COVID, and a little bit on timing. As a bariatric surgeon, you start to spend more and more time with your people of who you operate with and who you know. And you are a breast surgical oncology fellowship trained surgeon. So let me give a little background about you. So Dr. Gore is originally from Atlanta or the Atlanta area, and she attended Furman University in Greenville, South Carolina, uh, with a degree in biology. And then she went on and got her master's in public health at George Washington University in DC. And then she went on for additional education at Morehouse and graduated with her doctorate of medicine in 2011. And finally, after all those years of formal education, our paths crossed when you were a general surgery resident at Rush University Medical Center in Chicago and Cook County Hospital. And that is where I had the opportunity to get to know you a little bit. Frankly, I probably bossed you around a little bit because I was a chief resident and on my way out as
It's
you were
okay.
on your way in. And that's where we really started to see you share your passion for health, your compassion for patients, and you've continued to do that in your career now as an attending, as a grown up for quite a few years here. And then I left it out, but I didn't mean to. You did your breast fellowship at Maimonides in Brooklyn.
Yeah.
Yeah. So you've been back in the Atlanta area now for 5 years?
4 going on 5.
4 going on 5. It goes by fast.
Very quickly. Yes.
So I always like to use this opportunity to get to reconnect with some of my fellow Rush alumni who've gone on to do breast surgery, and it's a great opportunity to catch up with someone from across the country and talk a little bit about women's health because certainly in your field, you are taking care of lots of women, primarily women, and in my field, it's over half of our patients are women, although we certainly see men and take care of obesity in for everyone. So, without much further ado, let's talk a little bit about breast cancer awareness. tell us a little bit. I don't want to feel like I'm putting you on the spot and just like answer this, answer that.
No, go for it.
Let's talk a little bit about breast surveillance. So when we were in training, we kind of were teaching everyone you should do a monthly self breast exam. Is that something that we still do?
It goes all over the place depending on the organization. So, for example, United States Preventative Services Task Force will tell you grade C, maybe even lower recommendation, don't do breast self-examinations. American Cancer Society, so many societies we look up to and go to for information will tell you don't do it, not necessary. But I got to say, over half of my patients who were diagnosed with breast cancer found their own cancers or their partners found their cancers. And so I tell patients, and the National Comprehensive Cancer Network still recommends breast self-examinations. You got to know, you got to know your body, and you got to know what it feels like. In your case, especially dealing with bariatric patients, and you have patients who have a huge amount of loss of fat. I find that those patients, their breast exam and their mammograms always change with huge
Absolutely.
And I think it's very, very important. And I had a patient lost 100 pounds after a sleeve, and sure enough, found a mass. And so the breast is different, and I think it's absolutely important. Does it suck and is it hard? For sure, especially in premenopausal women, because you have more dense breast tissue. But I think I always tell people it's important to know the lay of the land. And that way, when something is abnormal, and certainly when something is grossly abnormal, such as skin changes, dimpling, whatever, you can easily recognize that and see it for what it is and seek attention quickly.
Right. I think that's really important. I would agree with that too, that knowing the lay of the land, understanding your body is really important, and recognizing those changes. I would say, and let me ask your opinion on this, does a self breast exam take the place of a clinical breast exam, seeing your PCP, gynecologist, somebody once a year?
And they should be doing it. I find that so many primary care physicians, I don't know about you in certain examinations, but I find that primary care physicians, I think that they are overworked and underpaid. And I also think that there's a certain baseline level of uncomfortability with doing a breast exam, because they don't necessarily know what they're feeling for either. And so a lot of people just completely omit it. But there have been studies that have shown that this yearly exam is important, especially since they are the gatekeepers. They're usually the first person a patient goes to before they even see me. And studies have shown that primary care physicians have found up to 20 to 25% of breast cancers. And so it's something that should absolutely be done. A lot of women use their OB-GYN as their primary care physician. And so if you're not going to a family medicine physician or internal medicine physician, you should certainly be going to your OB-GYN, and they should be doing a breast examination along with pap smears and other routine maintenance that they're doing.
That's right. But it turns out we need maintenance just like everything else. We have to keep that up. Just like our car needs an oil change and the air check in the tires.
Exactly.
Okay. So, I think surveillance is really important. And then how often and when should women be getting mammograms?
Every single year. So U.S. Preventative Services Task Force will actually say start at 50. That's a no-go. Do not pass go. Do not collect 200. Okay, that is not okay. American Cancer Society says between the ages of 40 and 44, consider starting your mammograms, and then begin annual mammograms at the age of 45. All the organizations that we actually look to, for example, ASCO, NCCN, even the American College of OB-GYN, we recommend starting at 40, and this should be done every single year. Every single year. And at least for my patient population, I would say the studies say about 10% of cancers are diagnosed under the age of 45. I would venture to say that at least 30 to 40% of my patients are under the age of 45 with the new breast cancer diagnosis.
Yep. Yeah, it seems like it's happening earlier, younger ages.
My youngest is 20, actually.
Yeah. And What about people who have a family history of breast cancer? Should they start their mammograms earlier, or does it depend? Something you need to have a discussion with your doctor about, or is there kind of a hard and fast rule of how early to do that?
There's not necessarily a hard and fast rule, but if your mom, for example, was diagnosed at 35 and you have a lot of women diagnosed under the age of 40 with a breast cancer, it goes without saying that even if you have not had genetic testing to confirm that there's something genetic going on, that this is a familial process and you should strongly consider starting before the age of 40.
Mm-hmm.
Recommendations and guidelines have changed. For example, it's known that African American women and other minorities will be diagnosed or more likely to be diagnosed under the age of 45. And so it's recommended they actually start screening mammograms at 35 years of age. And that's from the American Society of Breast Surgeons. Extensive family history, I always say get genetic testing. If it's positive, obviously you're going to start your screening mammograms at 30. From that point, before then, starting at 25, clinical breast examinations and MRIs. So no hard and fast rule. I think it depends on the situation. For example, I have a woman in my practice. She's in her early 20s. Every single woman in her family on her mom and dad's side gets breast cancer. Moms, sisters, aunts,
Wow.
like everybody has breast cancer, and it's usually under the age of 45. Everybody's genetic testing has been negative, but obviously there's something genetic going on. And so she started her screenings at 25 with MRI.
Yeah, I think that's something really important, more dense breast MRI. And there are some insurance companies that kind of dictate how we go about that as women. So you still have to have that clinical breast exam, and you may still have to have a mammogram that's inconclusive before they will pay for that MRI. So it does lead to those additional steps, but it's still important. Hopefully one day we'll get to where MRI can be that standard imaging for dense tissue.
And right now it's pretty much accepted as an indication for MRI. It's very important that your radiologists are on the same page and put that, because if they don't put that, consider MRI or strongly suggest MRI, then it's less likely that insurance will pay for it. I spend a lot of time on the phone with insurance companies.
I bet. And your patients thank you for that, because being an advocate is so important, and it's something that we both have to do in our professions. You mentioned a couple times some guidelines from the American Cancer Society, and I wanted to highlight something that you do in your free time when you're not operating or guiding patients or doing speaking events, and that's you are the chairperson for the American Cancer Society in Atlanta, and this weekend is the Making Strides event, which is their yearly walk. Give us a little blurb about that. I know you've put a lot of work into it, so give us your spiel. We may not make it from Dallas to Atlanta to see you, but we'll be there in spirit.
Yeah, I spent a lot of time with it. We raise money for American Cancer Society, specifically for the breast cancer arm. So the Making Strides Against Breast Cancer is their big walk in October every year. And it's at different locations each year throughout Atlanta. But it's a fabulous cause because we help provide screening mammograms for women who can't afford it, lodging for women who have a breast cancer diagnosis and are going through treatment, any other help they need from a treatment and support standpoint, rides to and from appointments, research, breast cancer research. And so it's such a worthy cause.
Yeah, absolutely. And I really think those really functional uses that patients really see, the getting people to appointments and helping with housing and lodging. And that's something that the American Cancer Society does all over the country. So certainly the chapter in Dallas does that as well. And a very, very worthy cause. So I would like to say thank you for doing that and being involved in that. For anybody that's interested in that, you can definitely go to the American Cancer Society website and learn more about Making Strides, and really see that that donation in action. One of the hospitals that we operate is at Methodist Dallas, which is on just south and west of downtown Dallas, and our office is right there on the campus. Methodist has a mobile mammogram unit and works to provide that outreach throughout the city. And they've got some free mammogram events coming up. So for anybody who's out there watching and you haven't had your mammogram, go get it.
Yes.
It's not my favorite day of the year, but guess what? I'm over 40 now and I do it generally. So my birthday is in September. So generally during my birthday month, I go to the dentist, I get my eyes checked, I get my mammogram, and I get my flu shot. And then I'm done.
That's a good idea to just do everything around during that month and get it over with.
Right.
You don't forget.
Yeah. So you don't forget, October gets really busy. So
October is
oh my God. Busy.
Yes.
And then it's the holidays. And so if you have a summer birthday, just do your upkeep at your birthday or around it. Or maybe you have a day that you don't like. Maybe you have an ex and you want to go do those things you don't like on your old anniversary or the day your divorce was final. I don't know. I'm just thinking of random days that might stick in your brain so you don't forget.
One thing I think that is important to say is that ultrasound and some of these other imaging modalities are not a substitute for mammogram, because mammogram picks up on things that aren't necessarily seen on other imaging modalities. And so, yes.
Yeah, mammogram.
They're uncomfortable. Nobody really cares to do it. I had to get my first one this year. And so I popped some ibuprofen about an hour before, and it went by pretty quickly. And
maybe Tylenol for our post bypass patients, but otherwise perfect.
Yeah. I'm a big fan of Tylenol and ibuprofen, whichever one you're allowed to have. Take it about an hour before.
Yeah,
it's not that bad.
Not that bad. Not that bad. So let's talk a little bit about some common myths, things that you hear on the interwebs or in your office. Things like my underwire bra is going to increase my risk of breast cancer. Is that true?
False. Completely false. Yes.
What if I sleep in it?
That will not cause breast cancer.
Okay,
at
good.
all. Don't worry, guys. If you want to wear your bra, wear your bra. It's okay.
I mean, I don't, but
especially during COVID.
TMI.
That was the mask before the mask, right? Like as soon as you get home, just take it off. But yeah.
Yeah, we've had to get dressed up to go out in public forever. It's not that hard to add the mask. Juanita is telling us that she's got her mammogram scheduled this month already. Very good, Juanita. Thank you very much. Good job. What about other myths?
Deodorant that contains aluminum. There have been actual studies on this. Deodorants that contain aluminum will not increase your risk of developing breast cancer.
Okay.
What's another one I get?
What about dryer sheets? I feel like somebody told me that one time.
No. No. Absolutely not.
Because
another one I've heard, if somebody has cancer and you do surgery, will you spread it by cutting the breast? Will you spread the cancer all over the place? That is such a 1850s way of thinking about surgery, and making an incision doesn't spread malignancy. And I think that's something very important to know. And I think some myths are definitely rooted in culture. I hear it a lot, from my African American patients and my Hispanic patients, but that's unequivocally false. So.
Yeah. The truth is, whether it's breast cancer, colon cancer, or anything else, if those abnormal cells are there, they're there. And so our job as surgeons is to go and remove those abnormal cells and limit the damage they can cause, limit the spread that they've already led to. And then we lean on our colleagues that are oncologists to get anything that might remain behind.
Yes.
Um, what about,
Getting a mammogram will not increase your risk of getting breast cancer. That's another big one.
yeah, that's a really scary myth to think might be true that
Yeah.
really limits that access, or not access to care, but limits approach to care. What what do you think is um, the big next thing that might change the way we take care of breast cancer or diagnose it? What do you think? Look into your crystal ball, Dr. Gore, and what do you see 5 or 10 years from now that you think may be really different?
I think if
I did not give you this question ahead of time.
You
Sorry,
did not.
everybody.
I think it's genetic testing because 23andMe, all of these things are so popular, right? And genetic testing is extremely popular even before a patient has a cancer diagnosis. I think if things continue to go the way they're going, we'll find a way to target a patient's individual genes and prevent cancer before it
Yeah,
can even start, honestly.
yeah. I think that is where some of those really targeted therapies are heading,
Yep.
which is really great. Um, One other thing that I wanted to talk about with you was about weight management and weight loss. We talked a little bit about, people have changes in their breast density and breast tissue after um, after weight loss surgery. So definitely knowing the new lay of the land. But let's talk a little bit about how weight loss decreases cancer risk.
I think on top of just making you feel so much better about yourself, weight loss has a huge impact on cancer risk reduction, I think, across the board, but
Hmm.
specifically as it relates to breast. Our fat cells are the largest reservoir of estrogen and progesterone outside of our ovaries. And so
Right.
the larger we are, the more fat cells we have. And the body is very cunning. It knows how to turn our fat and our hormones from our adrenals, which are mainly fat based, also. It knows how to turn those hormones into estrogen and progesterone. So it goes without saying, the larger you are, the higher your BMI is, the larger your estrogen and progesterone load, so to speak.
Hmm.
Those increased levels of estrogen and progesterone absolutely increase your risk for developing breast cancer. And in most patients, but certainly postmenopausal women, the overwhelming majority of those cancers are estrogen and progesterone positive.
Right. Right. So when we intervene with weight loss surgery and we decrease those fat stores, we are therefore decreasing cancer risk.
Absolutely.
And there's some good studies that are starting to come out to really quantify what that risk is, um, and especially in that postmenopausal group of women. Uh, and I wonder if the rare but certainly described breast cancer in men are those usually estrogen positive as well?
They are actually. They
Yeah.
are. And I have a fair number. I have quite a few men in my practice as well.
Hmm.
And most of their tumors are estrogen and progesterone positive. And we do the same thing that we do for women after
Yeah.
surgery. There are no studies to indicate that breast conservation in a man, especially since they already have very little breast tissue, we don't do that.
Hmm.
Almost always end up with mastectomy unless they are very strongly against having their nipple and areola removed. But a lot of those patients end up on tamoxifen and some of the other um, anti-hormonal medications, just like women.
Yeah. Um, well, parting thoughts. Thanks for joining us. It's always good to think about what we're supposed to do for our yearly breast health. I think things that you've been great at reminding us about. Think about genetic testing in your family,
Mhm.
surveillance. 40 is probably the latest you should start getting mammograms. But if you've missed that window and you haven't started yet, you should still start getting your mammogram.
Never too
It's
late
not
to
too
start.
late. That's right. It's never too late. And then, we talked about some common myths and, yearly clinical exam, yearly mammograms. Anything else you want to add? Anything else you want to tell us?
No, I just always tell patients healthcare is self-care. And so self-care isn't always, candle and bubble bath. It's, taking care of ourselves and making sure we are our best self, whether it's exercising or going to see you to jumpstart weight loss or getting your screenings, your colonoscopy, your mammogram. So take care of yourself. That's a part of self-care too.
Well, I think that's really awesome. And I'm going to close with a quote from you and your mission, which is to teach and empower women. When women have all of the information and tools they need to thrive, which includes this self care, there is nothing they can't do. I think that's so awesome. It gives me like a warm, fuzzy feeling. And
Thank
I just
you.
want to say I'm so proud of you.
Thank
I
you.
think you are doing wonderful things out there in Atlanta. And hopefully our paths will cross in person soon. It would be wonderful to see
They
you
will.
and
Don't
uh,
worry.
they will. They
They
will. It's really good to see you. And this will get saved on our Facebook page. So
Okay.
I'll pop back over there and look for questions from people. And when I find some I can't answer, I'll be reaching out to
Yeah,
you to
absolutely.
get some more answers. But thank you so much. Have a good day.
You too. You're so
Good to see you.
likewise. Thanks for having
Okay,
me.
bye everybody.
Bye, everybody.